So continuing with our look at anatomy with motion as the central part of our network of meaning or our semantic network, also with the clarification that I made in the elbow flexion video that I should have made from the beginning of the series, that whichever movement that we're talking about, we're speaking about it as if this is the diagnosis. So in osteopathic manual therapy, the diagnosis is what the part prefers, right? So if the elbow is good at extending but bad at flexing, then we call it an extended elbow. So it's as if this is the motion that is preferred. So keep that in mind as you maybe hit this point and go back to the other videos or go forward to the subsequent videos or whichever order you're watching these in. Just keep in mind that whichever motion we're talking about, we're speaking about it as if it is the diagnosis. That is the preference of motion of the part that we're speaking of. So our objectives here, a specific discussion of what elbow extension is, planes and axis, general discussion of the muscles that extend the elbow, so really simple, triceps and anconeus. Very general discussion of the nerves that supply the muscles that extend the elbow, one nerve, the radial nerve. Very general discussion of the vascular supply, one artery, which is the profunda brachii. General discussion of the areas to assess and treat should elbow extension issues be suspected or reported. So quick overview of planes: sagittal plane, 50% cut of the body left to right. Horizontal or transverse plane, 50% of the cut of the body top to bottom. Frontal plane or coronal plane, 50% cut of the body back to front, with the axes being perpendicular. So sagittal plane, horizontal or transverse axis, horizontal plane, vertical axis, frontal plane, AP or PA axis. Elbow extension can occur anywhere because the elbow proper is the humor ulnar, so the humerus and the ulnar, humerus and the ulna, or the relationship between the two, is where the elbow extension and flexion happen. But we're speaking about elbow extension with the anatomical position as your neutral reference point. So arms at the side, palms up, or palms supinated. What you're discussing is extension or movement. So if we have the elbow flexed, extension is movement or opening of the elbow joint, or opening of the anterior surface, but approximation of the posterior surface. So you can flip your frame of reference, but it's essentially opening of the elbow joint or straightening of the arm. That is going to occur in the sagittal plane about a relative transverse axis if the arms are at the side and the palms are up. Now, that said, it can happen anywhere that the arm is. You can call it a different plane and axis, but that's only because the arm can move about in many planes, because the glenohumeral joint has so much motion or freedom of motion. But more or less, if you're going to discuss this, or you can find discussions of it, elbow extension and elbow flexion are in the sagittal plane about a transverse axis. The muscles, as I already noted, is the triceps and the anconeus. So the triceps being three-headed, some portions of it attaching primarily to the humerus itself, and then some portions to the scapula, so the infraglenoid tubercle. So there's some connection to the scapula, and then some connection to the humerus, and then some connection to the ulna. So the anconeus is not necessarily a prime extensor of the elbow. It obviously helps and kind of helps to unlock the elbow. So it's a little bit more angular. You don't absolutely see it in a clear way there, but the triceps tendon, you see quite clear on this, that the big white connective tissue piece that goes across the elbow in the picture. So that's, the elbow extension is almost all triceps with some aid from the anconeus. As far as the neurovascular bundle, you're looking at the profunda brachii artery. So it's coming off of the brachial artery and going backwards, subsequent to the teres minor, or sorry, rather the teres major, I believe, is where it's going to go backwards. So that's where you're going to get your blood supply to the triceps and continuing on down with the triceps and to the anconeus, and then the radial nerve coming in and around the same area. So it's going to start to come into the posterior aspect of the arm in the region of the teres major, and then descend down with the triceps, and then start to provide neural tone or motor tone and sensory tone as well, more or less, to the triceps, to the anconeus, and then to certain portions of the forearm as it gets past the elbow. But your neurovascular bundle is going to be the profunda brachii artery and the radial nerve, and then that's going to descend in relation to the teres major and to the tricep itself. Now, this is obviously very quick because there's not a lot of anatomy involved here. But as far as considerations for where you're going to assess and treat if the elbow is in extension, right? It prefers to extend, and it doesn't like to flex. You're going to think about the cervical column for the neurovascular bundle. You're going to think about the clavicle and the axilla. So as the brachial plexus exits the neck and then enters into the axilla itself, the reason that you're going to consider that with specific respect to the triceps and the radial nerve or the profunda brachii artery is because you want that axilla to not necessarily be putting any undue pressure or pressure that could cause a change in function with respect to the artery as it branches off of the axillary artery, as well as the brachial plexus generally as it starts to send branches off in relation to the brachial artery or the axillary artery in that area. You're going to consider the posterior soft tissues of the forearm. You're also, at least to some degree, going to consider the lateral aspect or the lateral border of the scapula, because the teres major and the lat may interfere with, on some level, with the radial artery, the radial nerve and the profunda brachii artery, or the deep brachial artery, depending on which term you prefer. So you're going to consider that, and then you're going to consider the posterior tissues of the arm, right, or of the humerus, so the triceps brachii, and the posterior and lateral surface of the forearm, right? So you're going to kind of get through here, come down, and that's mostly because of the general connective tissue, but also the neurovascular bundle as it descends. The other reason that you're going to consider the lateral surface of the scapula is because of the connection of the triceps to the scapula or to the infraglenoid tubercle. So it's almost the reverse of the biceps. So bicep being here, or elbow flexion issues, or an elbow being caught in flexion, you go here and here, being caught in extension here, and then down into the posterior and lateral surface of the forearm, because of how the connective tissue runs and because of how the neurovascular bundle runs. Now, your contraindications and red flags, as already noted in the elbow flexion, you're not going to be as concerned with major changes in cognition or dramatic or recent changes in cognition, because you've probably ruled that out by this point. You're narrowing your focus to the elbow and to the posterior surface of the arm. So it's not as likely to be there. Major recent changes in breathing, again, not as likely to be there if you're getting to the point where you're narrowing in on a particular elbow issue. But if those are present, you send those out, you don't treat. With respect to the elbow itself, once you're narrowed in there, you're considering known fractures or tears. So a known fracture or tear, you don't treat, because you can interrupt this or make it worse. So essentially cause more insult or more damage to the tissues. Suspected fractures or tears, you send out for further medical examination. If upon further medical examination, there is no issue noted, and that is conveyed appropriately from the medical examination to you as a practitioner, then you can treat. You just need to make sure, working from the outside of the body and not being able to see with the aid of image, knowing absolutely for sure that a fracture or tear is there is harder to do. That's why you send it out for further medical examination. You want to be sure that you're not going to harm the patient, which is why that further medical examination is helpful to both you and the patient.